Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which may prove useful in your line of duty. Welcome to part 63 of our Pharmacotherapy MCQ series, which measures in transplantation pharmacotherapy. Question number 1 reads, which of the classes of immunosuppressants listed below is known to modify the natural history of cardiac allograft vasculopathy, abbreviated as CAV, and to reduce the incidence of and progression of disease? Is it the calcineurin inhibitors? Are they the mTOR inhibitors? Are they the anti-proliferative agents, or are they the steroids, the corticosteroids? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. They are the mTOR inhibitors. Now, mTOR inhibitors such as sirolimus and everolimus have been shown to reduce the incidence and progression of cardiac allograft vasculopathy in heart transplant patients, to be specific. Now, while the calcineurin inhibitors such as tacrolimus and cyclosporin have become the foundation of maintenance immunosuppressive therapy, they are specifically linked to improvements in CAV. So they don't influence progression. Steroids, on the other hand, or the corticosteroids to be specific, often form part of a maintenance immunosuppressant regimen. And I'd like to add that they don't confer any particular benefit in CAV. So that makes answer D wrong. Now, the anti-proliferative agents such as mycophenolic acid derivatives and azathioprine also often comprise a maintenance immunosuppressant regimen, but they don't confer any augmented benefit in the prevention or the treatment of CAV. So those many words make B the correct answer. I would just like to add that some immunosuppressant strategies in this population include the calcineurin inhibitor sparing regimens or reduced calcineurin inhibitor regimens. Now, this is typically done 7 to 11 weeks after the transplant to help reduce the risk of acute rejection. I would like to emphasize that the mTOR inhibitors inhibit vascular smooth muscle and fibroblast proliferation, and they have been shown to reduce the incidence and progression of CAV in heart transplant patients. So all those many words underscore the fact that B, the mTOR inhibitors, are the correct answer to that question. Let's move to the next slide, please. The next question reads, XPD, 56-year-old male patient, is admitted to your hospital. He He is scheduled for the placement of a left ventricular assist device, which will from now on abbreviate as LVAD. He has a past medical history of type 2 diabetes mellitus. He is hypertensive and he also suffers from coronary artery disease. He has been admitted to your hospital for 42 days. He's been with you for 6 weeks in the ward. His small bowel obstruction has complicated this particular admission, and he now requires nutrition through TPN. He is suffering from a nosocomial pneumonia, hospital-acquired pneumonia, for which he is on his 10th day of treatment with piperacillin tazobactam at a dose of 4.5 grams infused over 4 hours, 4 times daily. Your infectious disease specialist treating Mr. XPD considers him to be high risk for a fungal infection. The surgical team seeks your opinion as a team regarding perioperative antifungal prophylaxis. So my question to you is, which of the agents listed below would be the most appropriate for this indication for antifungal prophylaxis perioperatively? Is it fluconazole, liposomal amphotericin B, voriconazole, or micafungin? I'll give you 10 seconds to choose the correct answer. So fluconazole it is. Now the International Society for Heart and Lung Transplantation, which is abbreviated as ISHLT guidelines, recommend perioperative fluconazole prophylaxis for patients at high risk for fungal infection during surgical procedures. Now a dose of 400 to 800 milligrams is the recommended dose at induction of anesthesia just prior to surgery, and it can be continued on a daily basis for up to 48 hours after device implantation. I would like to emphasize that echinocandins such as micafungin and liposomal amphotericin B are recommended for treatment and not prophylaxis, treatment of device-related fungal infections. Now, routine antifungal prophylaxis for LVAD implantation isn't recommended. And I would like to add that Candida species are the most common fungal causes of LVAD-related infections. That's just a by the way. Let's move to the next slide, please. And the question reads, which of the options listed below is for a potentially suitable one for bronchiolitis obliterans syndrome, abbreviated as BOS, in patients post-lung transplant surgery? Is it transiently decreasing maintenance corticosteroid dose, or is it initiating azithromycin at a dose of 250 milligrams taken orally thrice weekly? That's on 3 different days of a week. Or is it changing a patient's maintenance tacrolimus immunosuppression to cyclosporin? Or is it initiating clarithromycin, another macrolide, at a dose of 500 milligrams taken orally twice daily? I'll give you 10 seconds to choose the correct answer. So I would opt to initiate azithromycin at a dose of 250 milligrams orally thrice weekly. Now I would like to emphasize that bronchiolitis obliterans syndrome, which is abbreviated as BOS, is an inflammatory condition affecting lung transplant patients and is usually managed using cyclosporine or tacrolimus. Now, literature recommends switching patients from cyclosporine to tacrolimus if applicable for maintenance immunosuppression, and not vice versa. We don't switch from tacrolimus to cyclosporine. So that makes answer C wrong. And literature also recommends transiently increasing maintenance corticosteroid doses, particularly in changing a patient from cyclosporine to tacrolimus. Now, there is no data supporting using clarithromycin in the treatment of or in prophylaxis of this condition. I would like to add that BOS is a hallmark histologic finding for chronic rejection in lung transplant patients. So be very, very careful when you diagnose it. Now, azithromycin is administered for a minimum of 3 months, 90 days. It is a macrolide antibiotic which has immunomodulatory activities, and that is what makes it very, very useful as a treatment option for BOS. That's just a by the way. Let's move to the next slide, please. And the question reads, Mrs. ASV, a 69-year-old female, has a scheduled implantation of an LVAD due to her severe symptomatic heart failure refractory to guidelines directed medical therapy, which we abbreviate as GDMT. This lady has a past medical history of atrial fibrillation, chronic kidney disease, which is stage 3 to be specific, type 2 diabetes mellitus. She's hypertensive, she suffered from an MI in the past, and she is depressed. Her current medications include 81 milligrams of aspirin taken orally once daily, 20 milligrams of fluoxetine taken in the morning after breakfast, 35 units of insulin glargine administered subcutaneously in the evening, 10 units of insulin lispro administered subcutaneously with breakfast, lunch, and dinner, 12.5 milligrams of metoprolol succinate administered orally once a day, 5 milligrams of lisinopril taken orally once a day, 40 milligrams of furosemide taken orally twice daily, 12.5 milligrams of spironolactone taken once daily after breakfast, 5 milligrams of apixaban taken orally twice daily, and she also receives milrinone via continuous IV infusion at a rate of 0.5 mics per kilo per minute. Your clinical team intends to withhold this lady's home apixaban for several days prior to the LVAD placement or insertion. So my question to you is, which of the medications listed below would be the most appropriate for her anticoagulation in the immediate post-operative period, which is post-op day 1? Would it be apixaban, warfarin, unfractionated heparin, or eptifibatide? I'll give you 10 seconds to choose the correct answer. So I would settle for unfractionated heparin. Now, the International Society for Heart and Lung Transplantation guidelines recommend initiating anticoagulation with IV unfractionated heparin, abbreviated as UFH, on post-day 1 or 2. I would like to add that warfarin is initiated later in the post-operative period, not around day 1 or 2. I'd also like to remind you that oral direct thrombin inhibitors and factor 10A inhibitors, that is apixaban and other drugs in the same class, haven't been studied extensively in this patient population and are therefore not recommended. There is no literature to back their use. Then alternative D, eptifibatide, is a glycoprotein 2B3A inhibitor, and it's not an anticoagulant, so that makes it totally wrong. I would like to add that intravenous unfractionated heparin should be initiated in the early postoperative period after mechanical circulatory support device placement to reduce the risk for pump thrombosis, which can end up in mortality. Now, thromboembolic risks of LVAD placement include pump thrombosis and ischemic stroke. I would like to remind you that a vitamin K antagonist such as warfarin should be initiated after postoperative bleeding is controlled and after chest tubes have been removed, not around day 1 or day 2. Now, risk of stroke is cited in various studies as approximately 10 to 30%, pump thrombosis approximately 1 to 12%, and GI bleeding risks at 15 to 30%. That's just a by the way for your information. Let's move to the next slide, please. And the next question reads, Mrs. T.O.O., a 60-year-old female patient, presents to your accident and emergency department complaining of a sudden onset of left-sided weakness accompanied by a facial droop. She has a past medical history of the ACC/AHA stage D heart failure, status post left ventricular assist device placement 9 months ago to be specific. This lady also suffers from a coronary artery disease. She suffers from rheumatoid arthritis and even pulmonary arterial hypertension. So my question to you is, which of the laboratory values listed below would be the most important to collect on presentation alongside blood glucose and a CT of her head? Would it be troponin, ESR, the PT-INR ratio, or all of the three? I'll give you 10 seconds to choose the correct answer. So C would be the correct answer. Now, standard therapy for patients with an LVAD includes anticoagulation with a vitamin K antagonist such as warfarin. Now, the International Society for Heart and Lung Transplantation guidelines for mechanical circulatory support recommend evaluation of a PT to INR ratio for all patients with LVAD presenting with a new neurologic deficit, such as this case. Now, for patients with the ischemic stroke presenting less than 3 hours from the symptom onset, the PT-INR ratio above 1.7 is a contraindication to treatment with a tissue plasminogen activator such as alteplase. Now, in the 3 to 4.5 hour window, any anticoagulant use, regardless of INR, is a contraindication to TPA. So I'd like you to remember that. Now, an elevated INR with a diagnosis of hemorrhagic stroke may warrant reversal of anticoagulation. So be ready to make that intervention. And I would like to add that ESR and troponin aren't routinely collected in the assessment of patients with new neurologic deficits, and they would be unlikely to alter treatment decisions anyway in this kind of scenario. Now, patients with the LVADs are at a risk of hemorrhagic and ischemic strokes. Therefore, obtaining a PT to INR ratio at presentation for neurologic symptoms is highly recommended. Now, just like to refer you to the endurance trial, ENDURANCE, endurance trial, According to that trial, ischemic stroke occurred in 17.6% of patients with what we call the heart-wear device, and 4% in patients with a HeartMate 2 device. That's just by the way. Let's move to the next slide, please. And the question reads, Mrs. WMM, a 60-year-old Kenyan female, status post deceased donor kidney transplant secondary to hypertension, presents to your hospital with a past medical history of hypertension, chronic kidney disease, hyperlipidemia, and hypothyroidism. A maintenance immunosuppression regimen comprises of tacrolimus at a dose of 2 milligrams orally twice a day, mycophenolate mofetil at a dose of 1 gram taken orally twice daily, with a dose of 5 milligrams of prednisone taken once daily. My question to you is, which of the characteristics listed below isn't a risk factor for new onset diabetes after transplantation, which is abbreviated as NODAT? Is it age above 60 years of age, the black race, that is black Americans and black Africans, hypothyroidism, or immunosuppressant regimen containing prednisone? I'll give you 10 seconds to choose the correct answer. So hypothyroidism it is. Now, in addition to risk factors for type 2 diabetes mellitus in the general population, other risk factors for NODAT include age 45 to 59 years, which confers 90% increase, age above 60, which confers a 160% increase in NODAT compared with the age in the bracket 18 to the 44 years group. Then there's also the black race, Hispanic race, prior hepatitis C infection. Even when a patient is overweight or obese, they are at a higher risk. And also there's the issue of ganciclovir treated and asymptomatic CMV infections. And then there's what we call the TC47L2 gene variant. If it's present, then such a patient is at risk. Then there's also hypomagnesemia induced by the use or administration of calcineurin inhibitors. I would like to emphasize that certain immunosuppressant regimens, including the calcineurin inhibitors, steroids, and the mTOR inhibitors, can contribute. And many immunosuppressants, such as steroids, are also diabetogenic. And remember, patients may develop NODAT, or they may experience a worsening of previously known diabetes when they're on such medication. So be very vigilant as you initiate therapy in these transplant patients. Let's move to the next slide, please. And the question reads, which of the statements listed below best describes the mechanism of action of Rituximab? Is it an IL-2 receptor blocker? Is it a monoclonal antibody against C5? Is it a monoclonal antibody against the C20 antigen? Or is it a proteasome inhibitor? I'll give you 10 seconds to choose the correct answer. So it is a monoclonal antibody against the CD20 antigen. Now, alternative B refers to eculizumab, which is the known monoclonal antibody against C5. Bortezomib, on the other hand, is the most commonly used proteasome inhibitor, and is used in the treatment of multiple myeloma and what we call antibody-mediated rejection, abbreviated as AMR. And then Basilicimab is an induction agent targeting the IL-2 receptor. I would like to emphasize that Rituximab, Eculizumab, and Bortezomib all represent medication options that may be utilized in the treatment of antibody-mediated rejection. Now, although Basilicimab is a MAB, monoclonal antibody, its use is in the immune system induction rather than the treatment of antibody-mediated rejection in transplant. That's just a by the way. Let's move to the next slide, please. On the next question reads, Mr. SOJ, a 56-year-old male patient, presents to your hospital with the chief complaints of fever, chills, weakness, and an altered mental status for the past 2 days. He has a past medical history of SCC, stroke HA, stage D heart failure, with a left ventricular assist device implantation, which was done half a year ago. He suffers from type 2 diabetes mellitus, he's hypertensive, and he also suffers from coronary artery disease. Your lab has isolated Candida glabrata in 2 of his blood cultures, and the susceptibility is pending, and that makes the choice of antifungal agent a bit tricky. Now, the source of infection is confirmed to be the left ventricular assist device pump. So my question to you is, which of the medications listed below would be the most appropriate choice for the management of this fungal infection in the case of Mr. SOJ now? Would it be IV micafungin, isovuconazonium sulfate, flucytosine, or fluconazole? I'll give you 10 seconds to choose the correct answer. So I would settle for IV micafungin. Now, treatment with a high-dose echinocandin, such as micafungin or liposomal amphotericin B, is recommended for pump or cannula infections by the International Society for Heart and Lung Transplantation guidelines for the management of fungal infections. Now, the IDSA recommendations for patients with candida infections of implantable devices also agrees with this. And I'd just like to emphasize that dose-dependent susceptibility to fluconazole is common among Candida glabrata isolates. However, it shouldn't be used until susceptibilities are known. That makes D a weaker choice, because the strain of Candida glabrata could actually be intrinsically resistant. I would just like to emphasize that isovuconazonium sulfate is used to treat invasive aspergillosis and in some cases of mucormycosis. Flucytosine, on the other hand, may be added to treatment with amphotericin B, and it should never be used as monotherapy because resistance emerges very quickly. I would like to add that amphotericin B is incompatible with normal cell line. So existing IV sites should be thoroughly flushed with 5% dextrose before and after the administration of amphotericin B via infusion. I would also like to warn you as care providers that infusion-related reactions are very common with amphotericin B. Therefore, you should consider pre-medication with diphenhydramine and IV paracetamol, say 30 to 60 minutes before you initiate the infusion of amphotericin B. I would like to add that chronic suppressive antifungal therapy is recommended to prevent recurrence after treatment completion. And device change or placement on the heart transplant lists is at times recommended for cases where there is relapse of infection despite the choice of antifungal having been appropriate. So always keep your options open. Have an open mind when you approach the management of such patients. Let's move to the next slide, please. And the question reads, which of the following is a common hematologic complication of long-term mechanical circulatory support? Is it polycythemia vera? Is it neutropenia? Is it acquired von Willebrand syndrome? Or is it hemolysis? I'll give you 10 seconds to choose the correct answer. So both answers C and D are correct. That is acquired von Willebrand syndrome and hemolysis. Now, acquired von Willebrand syndrome and hemolysis are common causes of bleeding in patients with long-term ventricular assist devices. I'd like to add that acquired von Willebrand syndrome occurs in nearly all patients with continuous flow LVADs, and it's believed to be due to shear stress inducing conformational changes to the von Willebrand factor protein, and that results in cleavage by what we call the ADAMTS-13. Now, the International Society for Heart and Lung Transplantation guidelines recommend evaluating patients with an unexpected drop in hemoglobin levels for hemolysis, and routine periodic screening for hemolysis with plasma-free hemoglobin and lactate dehydrogenase are recommended for the duration of device implantation. So it can be very tricky and demanding. Now, I would like to add that polycythemia vera and neutropenia aren't related to mechanical circulatory support devices at all. Bleeding is the most common complication for any use of LVDA. That's just by the way, and I'd like to emphasize that bleeding episodes should prompt evaluation for hemolysis and for acquired von Willebrand syndrome. Always be on the lookout, be very alert, be very vigilant. I would also like to add that hemolysis in the setting of an altered device function may be indicative of pump thrombosis. Now, such patients should be admitted for medical optimization and possible device exchange. Otherwise, the situation could complicate even further. I would like to wind up by saying that acquired von Willebrand syndrome resolves after device removal. So let's move to the next slide, please. And the question reads, which of the tests listed below does the FDA recommend prior to initiating azathioprine therapy? Is it the G6PD test? Is it the TPMT activity test? Is it the CYP2D6 mutation test? Or is it the CYP3A5*1 allele test? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. It is the TPMT activity test, where that abbreviation stands for thiopurine methyltransferase activity. TPMT stands for thiopurine methyltransferase. Now, genetic polymorphism or polymorphisms affect thiopurine methyltransferase activity, and several studies indicate that patients with reduced TPMT activity are at a higher risk for severe myelosuppression, and individuals with one or more CYP3A5*1 alleles also show an increase in tacrolimus clearance, and they may require higher doses of tacrolimus to be therapeutic. So when you intend to initiate a patient on tacrolimus, it's necessary to determine their status, whether they have this allele or not. And I would like to add that alternative A refers to Depson. Now, Depson is a transplant medication in which testing for G6PD deficiency is indicated. Now, in G6P deficient patients, the administration of Dapsone may cause hemolytic anemia. So be very vigilant and be very careful. All those many words make TPMT activity the correct choice. Now, I would also like to add that several transplant medications require or necessitate genetic testing prior to initiation to help avoid and to prevent adverse drug effects. Now, testing for thiopurine methyltransferase, which is TPMT, should occur prior to the initiation of azathioprine, since reduced TPMT activity with concomitant azathioprine can cause severe myelosuppression. So be on the lookout. Watch out for that to avoid causing harm to your patients. So my highly esteemed viewers and listeners, that brings us to the end of this video, which is part 63 of our series. If this video benefited you in any way, I would like to remind you to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. I thank you very much for viewing it and for listening to me, and I sincerely appreciate your partnership, your continued support, and your kind collaboration. I look forward to interacting with you in part 64 of our Pharmacotherapy MCQ series. Thank you very much.